This narrated PowerPoint presentation focuses on a non-auditory evoked response that some audiologists record, and that is electroneurography, abbreviated ENoG. The topics that we're going to cover in the PowerPoint presentation are listed here, and I would anticipate that this will take roughly 45 minutes. So I'm hoping that all of you will listen to this narrated PowerPoint presentation prior to the class on Monday, March 6th. And during that class, Dr. Friedland, or at least at the last part of that 2-hour segment, Dr. Friedland will moderate a discussion on this topic, ENoG, and also the second topic for this week, which is somatosensory evoked responses. Now, we're going to begin by just talking about where you can get more information on this topic, because the PowerPoint presentation is just an introduction to the topic. Well, one source of information is on Canvas. It's a chapter in my first handbook of auditory evoked responses, which was published in 1992. And it's toward the end of the book. It's chapter 17. And in that chapter, I review ENoG, but I also talk about somatosensory evoked responses. So this chapter is a reading for both the topics that we're covering in these narrated PowerPoint presentations. And then, of course, there are other non-auditory evoked responses, so I talk about those. There's visual evoked responses, which you don't need to be concerned with. And then there's also electrical stimulated ABR, which we're also not going to focus on right now. Another reference on this topic of ENoG is an article I wrote with a colleague, an audiology colleague, Doug Beck. Some of you may have heard Doug speak. He's worked for different hearing aid companies, but mostly as an educator. So he's often on the road giving lectures. And this article is based on the lecture that I'd given for many years that was published in Audiology Online, which you're all familiar with. It's a very short article, so I would encourage you to read this article as well as the review of ENoG in chapter 17. And then we're going to, as we get into this lecture, we talk about some of the topics related to ENoG. I'm going to reference several other articles that have been published usually by otolaryngologists on the topic. Well, let's start by talking a little bit about how ENoG all was discovered and how it came to be. And as usual, as you know now from taking quizzes already in this course, I'll ask who discovered every response, and that includes ENoG and roughly when it was discovered. Incidentally, these two topics that we're covering in these narrated PowerPoints, that is ENoG and SSERs, are both the focus of quiz 4. So quiz 4 covers ENoG, SSERs, and intraoperative monitoring. Now that quiz is not due until sometime quite a bit later in the course, so don't worry about that now. But that's where you'll be tested on it. So let's talk a little bit about the history of ENoG. It was first reported almost 40 years ago, I guess almost 50 years ago. Isn't that amazing? And there were some articles that had appeared in otolaryngology journals, and also some presentations at otolaryngology conferences. And I was at that point, 1974. I just was working on getting my audiology coursework wrapped up. I had a master's degree in speech pathology, so right about that time, I was involved in my clinical fellowship training in audiology. I was already working as a speech pathologist at Baylor College of Medicine and Methodist Hospital in Houston. So at that time, I didn't know anything about ENoG. Um, but in a few minutes, I'll tell you right now, about 10 years later, roughly, early 1980s, um, I was a director of audiology at that time at the University of Texas Medical Center, a school rather, in Houston, literally across the street from Baylor College of Medicine, across a little street on the Texas Medical Center campus. And I worked, I was in the Department of Otolaryngology, and my chair of the Department of Otolaryngology was a wonderful guy who was an otologist. And he came back from a conference and he said, Jay, have you ever heard of ENoG, electroneurography? I said, no, I really haven't. He said, well, I just came back from a meeting where I heard a fascinating presentation on ENoG and how it can be used in patients with facial nerve paralysis and how it can be very useful in determining what kind of management the patient needs and really documenting the extent of the paralysis and whether it may recover or not. He said, do you think you could record ENoG in our clinic? So obviously I'm the director of audiology in the clinic, and he's the chair of the department. So of course I said, yeah, I'm sure we could do that. So I said, let me do some research on it and I'll get back to you. Well, fortunately, when I did the research, which just involved checking out some articles, which I'm going to show you in a moment, I realized that we were in good shape because we had auditory evoked response systems. We had two of them. One of them was smaller one. We rolled that up to the nursery and up into the floors when we had to do pediatric ABRs. And of course, we used it for newborn screening. You've already seen it. It was a blue device that we rolled around. I showed you a picture of it. It's the Nicolay CA1000. But we also had a bigger diagnostic ABR system or evoked response system, which had all kinds of bells and whistles. And because I had been working in the neuro-intensive care unit with neurosurgery and some anesthesiologists already at that point, this was the early to mid 1980s, there was a big trauma center there at the University of Texas Medical School. I had equipment that not only could perform auditory evoked responses, but it also had the option for electrical stimulation. So this equipment could be used to record both somatosensory evoked responses, which we'll discuss in another PowerPoint, but also it turns out it could be used to stimulate the facial nerve and record ENoG. So to make a long story short, I started to become competent in recording ENoG. I practiced on myself and on my kids and audiologists in the clinic, and I found that it wasn't that difficult to record, although as you'll learn later in this lecture, the analysis can be sometimes challenging. And a lot of important decisions are based on ENoG results. So you don't want to make a mistake. I mean, based on ENoG results, the patient may or may not go to surgery. And if you made a mistake conceivably, and it really could happen, some patients might not make the recovery they should. They may end up with permanent paralysis. Now, interestingly, I have colleagues, many of them I've known for now 40 years, and so right after I was approached by the chair and asked about ENoG, we didn't have internet then, but I made some phone calls, and I called a few of my colleagues who were in my position. They're directors of audiology at major medical centers like the University of Virginia or University of Michigan. And I said, hey, weird thing happened. My chair, Bob, came back from a meeting and asked if I knew anything about ENoG. And it was just fascinating because the same thing had happened to these other guys who were directors of audiology. They also, of course, their chairs and their otologists had gone to the same meetings, came back and asked them the same questions. So a handful of us, maybe 6 or 7, suddenly became experts. And no audiologists had been doing it. I'd never learned about it in my training, even in my PhD program. So we all became self-taught experts on ENoG and started to not only use it in the clinic, but also give lectures and workshops so that other audiologists could get up to speed. And that's actually what Doug Beck and I have done at a few AAA conventions. We've given 1 hour courses to get people up and running on this. So you may, if you end up in a medical center, if you end up working with an otologist or neurotologist, you may very well be asked to perform ENoG. Well, the person who first described it was a Swiss otologist. Um, and I forget where, I think he might have been in Basel, Switzerland, Basel. And his name was Ugo Fisch, Ugo Fisch, Fisch. And as you probably know, in Switzerland, they speak French and they speak German, and he was had more of a German background. And here are the first few articles, the 1994 article, but then the next article, 1980, that's when Dr. Fisch, went off on the lecturing tour, must have spoken at the American Academy of Otolaryngology Head and Neck Surgery in the United States. And that's when, around 1980, 85, 81, 82, that's when my chairman of otolaryngology and others started to hear him speak. And of course, any otolaryngologist, particularly if they're in a trauma center, which we had two, I think we had three life flight helicopters even back then in the 1980s at that hospital. Um, Otolaryngologists are the ones who are consulted to go up to the floor when somebody's had a very severe head injury, including a temporal bone fracture. So if a patient's got any risk or clinical signs of facial nerve paralysis or paresis is partial paralysis, then the otolaryngologists get called in, and usually it's the otologist or the neurotologist who's the consultant. And so obviously the more the information they can get about the person's facial nerve, the more quickly and more appropriately they can manage the patients. So, they were very, very interested, the otologist, in getting ENoG results. I mean, if I'd said, no, I don't think I want to do anything with ENoG, I probably would have been in a position where I had to anyway, but I jumped at the opportunity. I mean, not every day you can become an expert in something that most other people don't know anything about, but it's a very quick test. It can be done in usually 10 to 15 minutes. Obviously, you generate revenue, but most importantly, and it's it's stimulating and exciting to learn about a new technique and to develop the competency in recording a new response. But most importantly, I knew it was contributing to the management of these patients. Okay, so that's the historical perspective. It all started in the 1980s. Now, anatomy of the seventh cranial nerve. I hope that most of you have learned about the cranial nerves, the 12 cranial nerves, not just the auditory nerve, and you have a basic idea of the anatomy and physiology of the facial nerve. I don't know if you take a course in neuroscience. I'll have to ask you at the next class. But I know when I was in my PhD program, without a doubt, that was the best course I ever took in all my education. Um, it was a 8 hour course. It was given during the summer because most everybody didn't do anything but study and take that course. It had a lab. I remember Friday afternoons I'd spend all afternoon in a lab. All of us. I was in with medical students, neuroscience students, dental students. It was a huge, huge class. There were probably 250, 300 people in the class, and then they break up into groups. And we all had a brain that we could use. Well, I think we shared it, and we had a set of slides that we would review, which were slides of different um, neurological structures, including brainstem, et cetera. So it's a phenomenal course, and there was a big emphasis on all of the 12 cranial nerves, of course, not just the auditory. I mean, in fact, most of the information about the auditory system in this course was quite superficial because it was basically focusing on not just basic neuroscience and in the fundamental principles and of how neural activity is transmitted through the brain, but it covered all of the different systems, including the somatosensory system and auditory, visual, etc. So we're just going to quickly cover this. I'm not going to make you knowledgeable about seventh nerve, cranial nerve anatomy and physiology, but I do want you to understand some of the basic terms. So obviously, it's the seventh nerve uh, is close to the eighth nerve. In fact, they run through the internal auditory canal together. They both um, arrive at the brainstem in just about the same location, the seventh and eighth nerve. So almost anything that can affect one nerve could affect the other, whether it's a tumor or some type of inflammation, a virus, whatever it might be. And of course, even though audiologists are primarily focused on hearing and communication and the role of hearing in communication, um, we really can't carve out just auditory functioning in our practice when a person's got a lesion or a pathology or dysfunction that affects something else. So that's why we're into vestibular, for example. Even though we're audiologists, now audiologists, and for many years, audiologists have evaluated patients with balance problems and vestibular problems because obviously the ear is not just auditory, it's also serving as a peripheral vestibular apparatus. And even the facial nerve, which doesn't have directly any connection to communication or any direct connection to the auditory system, still is kind of within our purview and it's within our scope of practice because we understand, we have the equipment very often. For example, we have equipment to record acoustic reflexes, which involve the facial nerve. And of course, we can perform ENoG, and it's right in our scope of practice. So now there are some audiologists, including my mentor, James Jerger, who I mean, he once said to me, he said, "What are you messing around with the facial nerve for? What are you, doing these ENoG tests? We're audiologists." And I said, "Well, politically and practically speaking, it's a good thing to do because the otologists need it. We've got the equipment, and the patients are coming to the same clinic that we're working in." But then I also pointed out that actually we've been evaluating the facial nerve as long as we've been performing emittance measurements, or back then it was impedance measurements, because the acoustic reflex is dependent on the facial nerve. That's the efferent portion of the acoustic reflex arc. So the seventh cranial nerve comes out of or enters the brainstem and exits the brainstem. I should point out it goes both ways. It's a sensory nerve, although you think of it as a motor nerve innervating the face. There is a sensory component. So the pathways go into the brainstem and out of the brainstem, right near the auditory nerve in the same general area. So here's the point that I just made, that the facial nerve is a mixed nerve. So this is something that you need to remember. It's not purely motor, although we're going to focus on the motor aspect, that is its innervation of the facial muscles. It does have a sensory component. Why is that important? Well, if you're stimulating, I mean, why is it important to know? It's obviously important. It's important to know because if you're stimulating a facial nerve in a patient who has paralysis, you might at first think, well, they can't feel they can't feel the stimulation because their nerves paralyzed, but in fact, they may very well feel it. In fact, almost always they will tell you they feel like a tapping sensation. It feels like somebody's tapping their um, right below the ear where you're stimulating, because there are sensory fibers. Now, only 1/3 of the fibers are sensory, 2/3 are motor, so it's primarily a motor nerve. And the facial nerve has about 10,000 fibers. Now, I think I asked one of you how many fibers are in the auditory nerve, and I think someone might have said it, but if not, there are 30,000 roughly. So the facial nerve has about 20,000 less fibers than the auditory nerve. Um, Now you can have normal facial function even when some of the facial nerve is not working. So people have estimated that even you could lose up to 50% of the the facial nerve fibers and still have reasonably normal facial function. It'd be hard to determine there was a person had a problem. And the same is true for the auditory nerve. You can conceivably lose thousands of fibers, but they're serving hearing from, say, 5 or 6,000 hertz up to 20,000 hertz. So I mean, probably you could have lose 50% of your auditory nerve fibers and still have reasonably good hearing and be able to communicate. So that's not unusual. Now, there are 5 major segments in the facial nerve after it exits the brainstem. Of course, there are nuclei in the brainstem. There's a facial nerve nucleus in the brainstem, which is involved in the acoustic reflex. But we're just going to talk about most of the damage and dysfunction and problems you see with facial nerve in patients who are undergoing ENoG are not due to brainstem lesions, because that very often those would kill the person. Now, it's conceivable you could have facial paralysis with a brainstem tumor or something affecting the facial nucleus in the brainstem. But the problems we see are almost always affecting the facial nerve after it exits the central nervous system, the brainstem. So there's the labyrinthine, tympanic, pyramidal, mastoid, and then the stylomastoid foramen components. And this is a little diagram which you'll find in chapter 17 of my handbook, Auditory Evoked Responses, showing those different components. So basically, the facial nerve leaves the brainstem right next to, about the same location of the brainstem, the kind of the pons midbrain, or pons medulla, I should say, junction, right in that area, above the spinal cord. It's not coming out of the spinal cord. It's coming out of the lower part of the brainstem, and then it exits the brainstem and almost immediately enters the internal auditory canal, and it runs through the temporal bone. And it runs through the petrous portion of the temporal bone, which is the hardest. Peter was the rock. Petrus means rock in Greek. So it's running through a very, very dense bone. And then it comes down to the area of the ear, and it runs right medial to the middle ear space. So it's kind of skirting the cochlea. And so it's got portions in the temporal bone, but it's all in the temporal bone, but portions in the internal auditory canal. But then it runs right next to the middle ear, right in through that area. So any surgeon performing surgery anywhere near the ear always needs to know exactly where the facial nerve is located, has to document where it is. Now, the facial nerve ends up, after it goes through the inner ear area, in the middle ear area, comes out into the mastoid. There's a little, very tiny little opening, little canal, and then the facial nerve exits through a little hole in your head, which you didn't know you even had, just behind the ear in the mastoid, called the stylomastoid foramen. A foramen means hole. And there are other ones in the head. There's the big hole where your spinal cord comes up into your skull, and of course there's others. So these are the 5 components, and the damage that occurs to the facial nerve, whether it's trauma or virus or vascular or whatever the etiology, some kind of inflammation, always affects these areas, because the nerve is running through tiny little canals throughout. If the internal auditory canal, it's going through little passageways through the temporal bone near the inner ear and the middle ear, and then of course it exits through a tiny little passage and way in the mastoid and out a tiny little opening. So anytime the nerve is traumatized in any way, or is involved in an infection or some problem that results in inflammation. Almost anything that happens to the body produces some inflammation. There's just no room for the nerve to expand. So it's a delicate nerve, and it's not uncommon to encounter patients with some degree of facial paralysis, which again is facial paresis, facial nerve paresis. All right, so the nerve, now we're going to talk about the nerve exiting the skull. And if you look at this diagram, I think it's yellow. Again, I'm color compromised, but I believe that's a yellow color for the nerve exiting right below where the ear canal is. You see where there's an opening in the skull also where the external ear canal is, not the internal auditory canal. And so the main trunk of the nerve exits there. If we had a skull, if I were there on campus, I'd find a skull and I'd point out the stylomastoid frame. And next time you see a skull, just a skeleton head or a diagram, or not a diagram, but a model of the temporal bone in the ear, see if you can find the stylomastoid foramen. It actually exits the skull, and then it goes right through the parotid gland. That's another possible etiology for facial nerve problems, is when some surgeon is operating on a patient who's got a problem with the parotid gland, and they bag the nerve, they nick the nerve. Then it goes forward anterior through the parotid gland, which you can see in this diagram, and then it splits into two major divisions: the superior, which heads up toward the forehead and also around the eyes, and then the inferior division, which goes down to the mouth. Buccal means mouth, the mandible, and further down toward the neck. So this is just the general anatomy, and it's important to know this because you're going to be, in recording ENoG and studying it, you need to know where you're going to stimulate the nerve. Well, you can't stimulate it until it comes out of the head, at least in a clinical setting. Now, in the operating room, of course, the physician, the surgeon, the otologist can stimulate the facial nerve directly with a little probe while the patient's head is opened up. But we can't stimulate the facial nerve until it exits the skull, and that's at the stylomastoid foramen. And then we have to record it somewhere, and we usually record it in this fold or crease between the base of your nose, the outside of your nose, and the corner of the mouth. It's called the nasolabial fold. And we'll talk more about that shortly. All right. Well, there's a lot of etiologies, a lot of causes for facial nerve dysfunction. And I'm going to review them all, but I'm going to highlight a couple of them that you really need to remember. There we go. Um, well, one is mumps. We don't see this very often. Any virus, chickenpox is a virus. Guillain-Barré syndrome that's a horrible virus. Every now and then you'll hear about somebody with it. It just comes out of nowhere, and it can cause all kinds of cranial nerve problems. I had a kind of an acquaintance, sort of a friend acquaintance, a healthy guy, and that happened. He got that. He ended up paralyzed. He was in a nursing home for a while, and he didn't live too many more years. Actually, it's just horrible. A stroke, of course, anything that affects the central nervous system, particularly the brainstem, can affect the facial nerve function, but it's really affecting the coordination for the facial nerve function in the brainstem, not the nerve itself. A tumor in the middle ear. We talked about the course of the nerve going near the middle ear. So a glomus tumor could impinge upon the facial nerve. A meningioma, which is normally in the cerebellopontine angle. Facial nerve neuromy. They're very rare, but there are tumors that arise from the facial nerve. And then, of course, trauma. So in terms of how often you see patients with paralysis in an otolaryngology clinic and an audiology clinic, trauma, particularly if you're in a trauma hospital, as I was and have been, in the past, that's a very common cause. Sometimes it's um, cranial trauma, like a temporal bone fracture, which is sometimes people put separate that from just head injury, which is not resulting in a fracture of the temporal bone. And then also there can be surgical trauma. So some of my patients have been referred to me by oral surgeons, or an otolaryngologist referred the patient to me, but they had previously seen an oral surgeon for surgery on the temporomandibular joint, and the oral surgeon had nicked the nerve or maybe even severed the nerve, trying to do something to the temporomandibular joint. So trauma is one of the more common etiologies. But by far, certainly in terms of non-traumatic etiologies, by far the most common is Bell's palsy. So we're going to get to that and talk about that much more in the next few slides. But let me just finish up the list. So Ramsay-Hunt's another virus. You'll see some of the reference to that in some of the articles that I'm mentioning. Iatrogenic. Anytime you hear the word iatrogenic, it means uh, it's a violation of the Hippocratic Oath, I guess, that somebody tried to help somebody and actually hurt them. So it could be surgically induced, or it could be medically induced, like a medical error where somebody is given the wrong drug or too much of the right drug, too many drugs, bad combination. That's all. Anytime you see the word iatrogenic, it means somebody caused it, usually a healthcare provider. Um, then we have the specific trauma to the temporal bone. For example, in a motor vehicle accident, or somebody falls off of a table or chair or something and hits their head, anything that might affect the temporal bone. Otitis media is very unusual, certainly in the United States and developed countries. Now, you could go places in the world where a person who has otitis media never sees a physician, never sees an otolaryngologist, never receives any management, and the infection just runs wild and eventually affects the facial nerve. That can certainly happen. Herpes zoster is another virus. Um, Multiple sclerosis, of course, can affect any nerve, mastoiditis, and then a neurological disease, Melkerson-Rosenthal syndrome. So many, many etiologies, but the two most common would be Bell's palsy, which is by far the most common non-traumatic, and the second would be trauma. And if you're working in the Department of Otolaryngology, it's usually temporal bone trauma. So let's talk about Bell's palsy for a moment. We're coming up on half an hour in the lecture. Well, it was named after Sir Charles Bell, and he was an interesting guy. Felt as if I should know a little bit about him. He's Scottish, and I've been to Scotland several times. Always enjoyed it. I've actually seen plaques for him in Scotland where he might have lived or worked, and he was a very smart guy. He was a philosopher, a theologian, a neurologist, an anatomist, but he was also a physician. He was supposed to be a surgeon. And I mean, that was what he was trained for, but he was not a very good surgeon, technically. He was always causing problems when he operated. And so his colleagues said, you're really smart. You should focus on research and writing, and because you're good at that, and stay away from the surgery, which he did. I'm not sure if he ever created Bell's palsy in one of his patients, probably not. But he's the first person who put together this constellation of findings from a history and physical findings, from the physical examination and the natural course of the disorder, and came up with a very good description of facial paralysis with no obvious etiology, no trauma, not secondary to chicken pox or herpes virus or something, just kind of a spontaneous paralysis that comes out of nowhere. In fact, patients will tell you, I went to bed, everything was fine. I was brushing my teeth, combing my hair or whatever, looked in the mirror, everything was good. My smile was symmetrical, and I woke up in the morning, and first thing I noticed, I had drool, or I was drooling on my pillow, and I went in to brush my teeth or went in to get a drink, and the water kept liquid kept coming out of my mouth. And I looked at myself, or my wife or spouse or child or somebody looked at me and said, "What's wrong? One side of your mouth's not moving." And then, of course, they realized they couldn't close one eye either. So it comes on almost literally overnight, very, very suddenly. It's not that uncommon. The worldwide incidence is 0.02%. It doesn't sound like much, but that's really quite prevalent. And equal distribution for left and right side, equal distribution in males versus females. Older children are older people are more likely to have it just because they've lived many more years. But it is possible in children. I've seen children with Bell's palsy, not infants, but older children. Now, comorbid conditions play a role. So, for example, diabetes is going to put you at risk for Bell's palsy, and also there is also a higher risk in the third trimester of pregnancy for whatever reason. So those are some facts about Bell's palsy. Um, One real serious concern, this is something you need to know. Even if you're not performing ENoG, you may very well see patients in clinics with facial paralysis, and they're going to ask you questions. They don't, they figure, well, this person's here, they're an audiologist, they should know something about my problems. So they may say, I'm really worried that this is going to happen on the other side. I've already got paralysis on one side. It's really, really emotionally devastating. We'll get to that more in just a moment. And they might say, but does that mean I'm going to have it on my other side? And the likelihood of having paralysis on the second side from Bell's palsy is no greater than it is in the general population. So the chances of getting in the other side it's not going to happen, almost certainly not going to happen. But if it does, it's not related to the Bell's palsy that they've already had. It's not contagious. It's viral issues that affect the ear and facial nerve are not the kind that spread. They're kind of contained within the body. And as I said a moment ago, that dry eye is a major problem because you can't close the eye. The muscles that are used to close the eye aren't working. That can be serious. It can dry the cornea, and you can end up with permanent problems. Because the nerve is a mixed nerve, sensory and motor, there may be some tingling in the mouth and the lips when the nerve is affected. Of course, the mouth is weak. Their speech might be a little slurred, and again, they drool and have trouble when they're chewing, eating, or drinking. Now, Bell's palsy usually is at its worst within 4 or 5 days after the onset, and then very often it starts to completely recover. Now, physicians like otolaryngologists, first of all, you got to get these patients to an otologist. They really don't. It's not good for them to go to their family doctor only. So if you have a friend or a colleague, or if you encounter somebody, I've just randomly encountered somebody at a restaurant or something who finds out that you're an audiologist and says, I've got this paralysis, or my wife developed this paralysis yesterday. What should I do? Tell them, get to an otolaryngologist right away, immediately, as fast as they can, because the sooner they're started on steroids and antiviral drugs, and sooner the management begins, the more likely recovery is. However, about 50%, half of everybody with Bell's palsy, just within the first couple months, will recover spontaneously. Of course, they don't know it at the time, so they're very worried. And then there's a smaller percentage that actually will still recover, but it'll take up to a year. And it's very, very rare, but you could have recurrence. So this is the same side. Maybe if it's viral, the virus never really totally left the body or was treated effectively. So there is a chance, about 8% chance of it recurring within the next 10 years. It's very uncommon for surgical intervention to be necessary, but it is an option. If the inflammation is clearly destroying the nerve, if there's totally degeneration of the nerve, as we record it outside the stylomastoid foramen with ENoG. If that is total degeneration and it's not changing, very often an otologist will operate. And basically what they're doing is trying to expose the facial nerve inside the temporal bone and drill off enough bone where the nerve is not being compressed. More commonly, though, the first step is just monitoring. Wait and see is what it's called, because we want to determine that whether or not this is going to spontaneously recover. You don't want to be beginning all kinds of heroic management strategies if in fact the patient's going to recover on their own. But meanwhile, you got to take care of the eye. That's very important. So people wear a patch so they don't get dust and dirt on it because they can't close the eye. Very often it'll be taped shut. They may use some kind of gel or ocular gel just to keep it moist, or artificial tears once a day. And of course, when they're out and it's bright in the sunlight, you really have to wear sunglasses because you can't always squint as you normally would. The medical management, as I said, it's steroids to reduce inflammation, and cyclovir is a antiviral drug. So if you have shingles, for example, which is a herpes zoster virus, I had it about a year ago, very painful. Fortunately, mine was only on the scalp. It's always on one side. Cyclovir is usually given, and it doesn't necessarily treat the virus, but it shortens the recovery period. Or speeds up the recovery period. Here's one of the articles I mentioned that I'm just going to mention. You don't have to read the article. A review article. They're looking at what are the typical attitudes or typical approaches to Bell's palsy, and how often is surgical treatment done. And of course, this is always going to be otolaryngologists. That they are surgeons that would understand facial nerve anatomy more than anyone else. And I was actually surprised when I read the results of this article or this study that 2/3 of the respondents, the otolaryngologists who were surveyed, the otologists, at least in the United States, said they would actually consider surgery to if there was total degeneration of the facial nerve as documented with ENoG. But they always start with steroids and always start with antivirals. And if there's still no recovery of the nerve, then they consider surgery. All right. Let's just talk a little bit about why this is such a difficult problem, or such a horrible problem for the person that has it. And some of you may know of a family member or a friend or some acquaintance or a coworker or someone that had facial paralysis, and you'll probably appreciate how debilitating it can be. Well, we are our face. Nowadays, when I try to make the point that this is a serious problem for someone, and you have to be very compassionate and understanding about it, even though it's not life-threatening to the person, it's just horrible. And the great analogy here is Facebook. Your face is what people identify you by, and we don't have a shoulder book, or nobody's going to start a knee book or a foot book, because one foot looks just like the other and one knee does, but a face is almost always unique. Everybody's face is kind of who they are to a large extent. So when your face is disfigured by paralysis, it totally disrupts your life. It has a very serious emotional and psychological impact on a person. They don't want to socialize. They're embarrassed to go out. They don't want to interact with friends or others. They don't want to travel. They don't want to go to restaurants because they look weird. They don't look like themselves, and they feel very, very self-conscious. That's all on the emotional, psychological side. Of course, then there are the practical problems: drooling and difficulty speaking. and inability to protect the eye, as I said. So there are psychological slash emotional aspects which are very debilitating, plus the physical. Okay, now ENoG is performed with an evoked response system which has electrical stimulation. It's a very technical way of assessing the facial nerve. And in my opinion, extremely valuable. You can get information from ENoG you can't get any other way. And the otolaryngologist, they're not doing ENoG, so they're counting on you to tell them, is this nerve totally degenerated? And to monitor the patient to determine whether there's any return of function, because looking at the person's face and asking them to do things with their face, like smile or close their eye, only gives you a partial picture. It doesn't really tell you a lot about what's happening. But most people don't have the equipment. Most people can't perform ENoG. Certainly, physicians in a typical office or an otolaryngology office, or if you're in a hospital, a physician, an otolaryngologist is in a hospital, and they're called to consult a patient who's got facial paralysis. They don't have ENoG, so they have to have some way of measuring the extent of the problem, of documenting or grading the severity of their problem. And so two otologists, William House, who started, he and his brother started the House Ear Institute in Los Angeles, and then an otolaryngologist who's been there. God, I was out there in the late 1970s and early 1980s learning about the very, very first cochlear implants. They're single channel cochlear implants when I was at the University of Pennsylvania directing audiology there. And I met this young otolaryngologist, young at the time, Daryl Brackman. Well, he's still there, I think. He hasn't retired yet. Anyway, William House and Daryl Brackman put together a six stage or six step grading system for facial nerve. So if you go to a hospital or if a person goes to an otolaryngologist, they're going to be definitely trying to grade the facial paralysis based on these six steps. And it all has to do with volitional motion. That is, how much the person can move their facial muscles when they're asked to. So if you have a patient that's paralyzed, who has facial paralysis, but they're in coma, they're comatose, they're unconscious, and then you can't use the scale because it all involves asking people to close their eye as tightly as possible, smile, move their lips, etc. It's all volitional. So these are the six grades. You don't need to memorize all of this, but I want you to be familiar with the House-Brackman grading system and to know that one is normal, without any doubt. Everybody would agree with that. Of course, ENoG would be totally normal. Two is mild dysfunction. Most people aren't even going to know there's a problem. Now, the person who has the paralysis they probably will, but certainly friends and maybe even family members won't notice it. It's very, very mild. Now, as you really, if you're around a lot of people with facial paralysis, as an audiologist clinically, when I'm in a crowd or I'm say at a dinner with people, I mean, I could pick up grade 2 for certain if I'm watching a person closely for a while. 3, it's quite obvious. It's obvious to not only the person, the patient, but also to anybody that meets them. But they can still, if they're just sitting, at least initially, soon after the onset of the paralysis. If they're just sitting there watching you or something, you're probably not going to notice because their facial muscles are at rest. So there's not much drooping at that point. And they may have a little trouble closing their eye. You may notice that one eye closes quickly and the other barely closes. Their mouth, when they smile, it may be a little uneven smile, but I mean, I've got an uneven smile. A lot of people do that don't have paralysis. So, sharp clinicians certainly would notice a grade 3. Or if a patient came to a physician and said, I think one side of my face is a little weak, and then of course that would tip the physician off, and they'd probably put them through their paces and smiling and closing their eye and begin to see that there was a problem. But ENoG is normal, 1, 2, and 3. No, the ENoG would be perfectly normal. Good fat, good large facial nerve response. Now, moving on down to categories. 4, there's no question it's a problem. It's disfiguring. The eye is not going to be closing, so they're going to need eye care. And 5, even worse, almost can't move the face at all, no matter how hard they try. Uh, Even when they're just relaxing, their one side of the mouth is drooping down. The two sides of the face don't look the same. And then, of course, the 6 is the worst. No movement, no matter what they do. And that's, you know, when you're called upon to do ENoG, almost always the patient's got a House-Brackman uh, scale of a 5 or 6. They don't really need to be doing ENoG before that, because you know there is some facial nerve functioning still, because they are obviously able to move their face. Okay, real quickly, um, the concept here is that when the facial nerve is damaged, when there's inflammation, there's trauma, there's a virus, something affecting the facial nerve as it runs through the temporal bone, um, the nerve, part of the nerve that's coming out of the stylomastoid foramen, and the parts of the nerve uh, that the superior and inferior division that go into the face, that's normal, perfectly normal. The nerve there is normal. That's not the part of the nerve that's been damaged or has been traumatized. But in time, there is a retrograde degeneration. That is, from the more distal portion of the nerve, the part that's going through the ear, that area, there is a degeneration that works its way out to the more um, distal area. So it's from proximal, I should say, from proximal to distal, from in to out. And that's called Valerian, or it should be pronounced Valerian, not Wallerian, because it's a German or Austrian name, degeneration. But just remember the degeneration. Don't worry about the Valerian. And it takes about 72 hours. So in the first 3, 4, 5 days from the onset of some paresis or paralysis, that degeneration works its way out. If it's going to happen, it may not. With Bell's palsy, there may be some paralysis, but never any degeneration. And then that's a very good prognostic indicator. So basically, it's a retrograde denervation. The nerve, is not being used. It's not functioning normally further toward the brain or in the temporal bone, and sooner or later that degeneration works its way out to the face itself. So I've had, I remember once I was actually at a AAA convention, and I was up on the stage giving a lecture on ENoG, or about to give a lecture. I guess I was waiting for somebody to speak before I would go up and talk about ENoG. It was quite a coincidence. And my phone, I saw this message, a text, saying, "Dr. Hall, can you call me right away?" And it was one of the residents that I worked with. This was at the University of Florida when I was head of audiology there. And I said, "Well, I've got a few minutes before my lecture. I'll run out and talk to him." And I called, and they said, "We've got a patient with facial paralysis, and it was a trauma, and we need to do an ENoG. Could you come do it?" And I said, "Well, geez, I'm not even, in Gainesville. I'm at this meeting wherever I was." I said, "We've got somebody that can do it, but when did this happen?" They said, "Well, it's just yesterday." I said, "Well, okay, there's no sense in doing the ENoG for the next 2 to 3 days, because any degeneration is going to take that long to develop, to occur. So I'll do this when I get back in the clinic. It'll be just about the right time." And then I got up on the stage to talk about ENoG, and I said, "Well, in case some of you wonder if this information is important," and I told them that story. It was a very practical example of how you need to know when to do certain procedures and when not to. In the first 72 hours, it's not going to give you any information. As long as there's any facial function at all, you know that there can't be complete degeneration. Now, what is significant degeneration? Well, this is an important point. This will pop up on a quiz, I can guarantee that. And that is when you compare the the involved side, the paralyzed side, to the other side, the uninvolved. You've got to make sure the uninvolved truly is uninvolved when there's been more than a 90% decrease in function. So we're going to talk about how to analyze the ENoG in a moment, but it's a wave. It's got a peak, and when the peak on the involved side is less than 10% of the peak on the uninvolved side, that is when the amplitude of the facial nerve ENoG response, which is really a muscle response, not a nerve response, but the nerve obviously is going to control the muscle response. When there's more than 90% degeneration, now you might be saying, wow, why wait until there's almost no function whatsoever? But the reason for the 90% rather than 50% or 75% is because there's so much variability from one side to the other. There's so much test uh, variability and also variability in symmetry. So everybody, if you tested them, and I've done this in a study, you find that huge variations in function of the facial nerve from one side to the other. So you have to make sure that it's really an abnormality on the involved side. Okay, I'm going to just quickly introduce you to some terms. This is not that critical for you, so don't be worrying about studying and remembering this. There are three types of facial nerve dysfunction, or three categories, three grades, you might say. Um, with Bell's palsy, it's a neuropraxia, which there's definitely some degeneration, but there's no trauma to the nerve. The fibers are all there. There's no severing of the nerve. The sheath around the nerve, the myelin, is intact. So they can't move their face, and that's really bad. It's frustrating for them and everything. But they'd have a great ENoG because the nerve itself is still reasonably intact, even though it's not working well. And so they're going to have a pretty good recovery. At the other end, we have total severing or damage of the nerve, not just the outer uh, insulation, outer um, sheath around the nerve, but also the nerve fibers themselves. And of course, if you perform ENoG, you get no response, a flat line. It's very obvious. And those are the patients where, they may actually need some type of anastomosis, which would be where a surgeon takes the two parts of the nerve that have been severed and connect them again. Although that's obviously very difficult to do. Okay, ENoG, real quick. And we'll finish. Looks like it's going to be an hour lecture, not 45 minutes. Okay, it's non-invasive. It's not going to puncturing the skin. You don't in a clinic. You don't do that. Now, if I'm performing facial nerve monitoring in the operating room, I do take subdermal needles and slip them underneath the skin near the nerve. But clinically, it's non-invasive. Um, the stimulation is not sound, obviously. It's an electrical stimulation, and the unit of how much stimulation you're presenting is the milliamp, small m, big A, milliamp. And you're presenting it in the region of the stylomastoid foramen, which I'll point out a little more closely in a moment. But the actual, what you're recording, it's not a nerve response directly, it's an electromyographic response. In other words, it's muscle. And that is recorded in microvolts. So the stimulus intensity is in milliamps. It's a current, constant current, electrical current, but the response you're recording is a muscle response, and it's in microvolts. Of course, since it's muscle, it's much bigger than the ABR or any electrical response you record from the brain. So you'll see it could be a 1,000 microvolts, you know, which, a microvolt's small still, but 1,000 microvolts is like 2,000 times larger than the ABR. So it's a muscle response, so it's going to be big. And your goal is always to record the largest amplitude that you can possibly get from each side, and then compare the two. One of the more common mistakes in ENoG is people kind of pussyfoot around. They don't want to give the patient too much stimulation, and they understimulate, and they're not recording the largest response they could get from the patient. And that's how you can begin to make mistakes in your interpretation, thinking that there's paralysis there when there really isn't. Okay. Um, As I've already mentioned, the only time you're really going to consider ENoG, I mean, if a physician says perform an ENoG in this patient, and they have their reasons for doing it. Of course, I will go ahead and be happy to do that. But typically, you're not going to be, if they've had the House-Brackman grading scale applied to them, you're not going to do the ENoG unless they're down at a 5 or a 6. Um, and of course, you can't really see a big difference between 5 and 6 clinically. I mean, if you're really talented and you're an otologist that does it all the time, but you and I would have a hard time making that distinction. And that's where the ENoG can be very helpful in determining whether there's 90% degeneration or not. So usually if the patient can move their face at all, you don't need to do an ENoG. You know, there's some nerves that are still intact. Now, it is possible to document progress or chart progress of facial nerve activity, and that's why some physicians would like it right away or within that first 72 hours. It's going to be perfectly normal. They'll say, okay, now we've got our baseline. Now we can determine how quickly it's degenerating, if it does degenerate, or we can monitor. We can do another ENoG in 3 or 4 days or a week, and it was normal, perfectly normal the first time, symmetrical, and then determine whether it's the same. And that's very helpful for the patient for counseling to say, we performed this test, your nerve is not yet degenerated. Yeah, you're not able to move your face, and that's a problem, but the nerve itself out by your face is still intact, and it hasn't changed in the last couple of weeks. That's a good sign. Okay, here's another article talking about two types of etiologies that we've already mentioned, Bell's palsy and Ramsay-Hunt. By the way, that shingles that I was mentioning, technically, I think that is a form of Ramsay-Hunt, or it can be in some cases. So basically, there was more degeneration in Ramsay-Hunt than Bell's palsy. Um, but so there was a slight difference, and the ENoG predicted non-recovery. That is, the degeneration of the ENoG response predicted non-recovery more accurately in Ramsay-Hunt than Bell's palsy. So this is good to keep in mind that the results, the conclusions you draw from ENoG won't necessarily be the same for all patients with all etiologies. There may be some variations. Here's another article about all in terms of prognostic value of ENoG, which is what you're usually using it for. It's to document the status of facial nerve, but also to predict whether or not there will be recovery. And this is the same, kind of general conclusions. They're comparing Ramsay-Hunt and Bell's palsy, and there are slight differences in the two etiologies. But the overall conclusion is really not that different. That is, you're using ENoG to document degeneration and to monitor or predict whether or not there's a possibility of recovery. The nerve. All right, measurement and analysis. Real quickly. You're stimulating not with earphones, not with sound, but with a pair of electrodes that generate a very, very small electrical shock. I don't use that word around patients, obviously, but that's what it is. It's a minor, very, very, very slight little electrical shock. It's a constant current. So if you pick 10 milliamps, machine's going to adjust the current based on the impedance of the electrodes to come up with 10 milliamps. And you present this constantly. This is kind of counterintuitive. You just keep presenting the stimuli about 1 per second, doop, 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 but it's not a sound, it's an electrical current. Just tap on your mastoid bone lightly, and that's pretty much what it feels like. And the reason the continuous is preferred is because a person does habituate to that stimulation. In other words, the more you stimulate, the more they don't notice it. They get kind of used to it. And if you constantly were turning the stimulus on and off, thinking you're being a nice person and not presenting the stimulus when you don't have to, it actually is worse for the person because it jolts them. They're not getting used to it. So it's better just to let it go as long as you're stimulating them. Always stimulate just one side, and you try to get up to the highest level of that you need to present, the highest level of current to get the biggest response that's not going to get any bigger. And that's called supermaximal. And I'll show you a diagram. All right, so here I am stimulating. This is actually an audiologist who's in Florida, but she was an extern when I was at the University of Florida, and so she said, "Oh yeah, I'll be happy to be a subject." So I'm stimulating. There's two little prongs at the end of that stimulation device, and I'm controlling a little knob there that's the intensity level of the stimulus. And I start at maybe 5 milliamps, and I go up to 10, record a response, go up to 15, get a response, and I keep going until the response doesn't get any bigger. And if I have to go up to 40 milliamps, that's the maximum, I'll do it. So over on the left-hand side of this slide, you see that yellow arrow. That's where the nerve's coming out of the stylomastoid foramen. So the electrodes are just below the ear, and one of them is on the mastoid, and that one right in that area, or both of them are really on the mastoid. And we try to kind of bridge or have one electrode on each side of the nerve as it comes out of the skull. Of course, we can't see where it is, so you have to move it around a little. Now, where do we record from? Well, we use an analysis time of 20 milliseconds, a filter settings quite wide. It's a very slow response. And we don't have to amplify much because it's not like 100,000 for ABR. It's 5,000 or less because it's a giant muscle response. And we put the electrodes on the nasolabial fold. So here's the nasolabial fold, corner of the nose down to the mouth. And there's a lot of muscles there. If you look at the little diagram on the left, there's just nothing but muscles. We're always using our mouth. I'm using my mouth to talk, you use your mouth to chew. So those muscles are very strong. So we want to get the electrodes, recording electrodes on top of these very, very powerful muscles around the mouth. One up by the nose and one at the corner of the mouth. Now, here's the concept of supramaximal. We keep increasing the intensity, which is on the horizontal axis, until we get no bigger response, no matter how high we increase the intensity. So we basically get up to where it saturates or flattens out. So with one of these, going from 0 milliamps up to about 10 milliamps, we almost got maximum right away. So with that one, I might go to 15 and it's not changing, I'd stop. But the other one, the more gentle curve, you can see if I'd stopped at 10, I would have been underestimating the function of the nerve. And I went up to 20, it still wasn't up to maximum. Had to get right up to 40 before I finally reached maximum. And there are some cases where you get to 40 and it's still not maximum, but that's as high as you can go. It's too dangerous to go to higher levels. So this is an important concept, supramaximal stimulation. How high, how many milliamps should you present electrical stimulus to a patient and when you're doing ENoG? And the right answer is you need to present them at the supramaximal level. You need to present them at the level where higher levels of stimulation will not give you any further increases in amplitude of the ENoG. Now here are the actual diagrams of the response. We're starting out at a lower stimulus of 10 milliamps. That's the lowest one. There's definitely a response there, but we can't stop there. We go up to 15, it's bigger. 20, it's bigger. 30, it's even bigger. But you can, it's not even bigger. Between 20 and 30, we've got 800 microvolts of response, and it's not changing. So that's where we would stop. Now here's another tracing. Normal ENoG at the top. Super maximal level is quite substantial. And again, it can be 1,000, it can be 750 microvolts, it could be even 1,500. There's a lot of variability. But clearly, the lower tracing, there is no response where there should be one. Now, if there's a very early peak, a really early peak, as you see in that top tracing, it's less than 6 milliseconds. That's not the facial nerve. That means you've usually are stimulating either at a high level or you've moved your electrodes a little anterior and you're stimulating the chewing muscle, the masseter muscle, and that's not what you're recording. So if you see a big peak before 6 milliseconds, it's not the ENoG, it's almost always the masseter muscle. Here's another example of a really good looking response on one side, no response on the other side where there's a temporal bone fracture. Okay, I'm going to wrap up in the last minute or two here by talking about some of the problems you can run into and how you solve those problems when you're recording. Well, if you're not getting any response bilaterally, then that's serious because usually you're dealing with somebody with a unilateral problem. So if you're in the operating room or the intensive care unit, neurointensive care unit, you have to find out, is the patient chemically paralyzed? Very often when a person's intubated, for example, they'll be heavily sedated and chemically paralyzed, which of course can eliminate any muscle function. Or maybe, and here's a more likely explanation, certainly in clinic, you're got the electrodes on nasolabial fold on each side, the right and left, and you're stimulating the right stylomastoid foramen near the right ear, but you're actually trying to record a response from the electrodes on the left side of the face. Well, you'll never get anything because this is all a ipsilateral response. There's no crossover from one side of the face to the other. All the facial nerve muscles on one side of the face are innervated by the facial nerve coming out of the stylomastoid foramen on that side. They don't cross over the midline. That's why when you have shingles or herpes zoster, it's always on one side, never on both sides. So what do you have to do here? Well, I've run into this, and I said I'm going to have this patient's chemical paralysis eliminated just temporarily. In the operating room, they can do that pretty quickly. In the ICU, they may not be able to quite so quickly. Or obviously, if it's an electrode problem, you have to just correct it. Usually, it's just a question of plugging in the proper electrode. Okay, so there's now that we still got a bilateral problem, but it's not no response. It's a small amplitude. Well, this is most commonly in patients who have had trauma, a lot of edema throughout the head and neck, and or in a clinic, the person's very tender, they've got some pain, maybe they had their whole head and neck was injured, and there's a lot of trauma, and they just don't want you to press very hard. You've got to press these two prongs. The electrodes are prongs. You've got to press them, uh, particularly in patients who have a lot of fat tissue there, who are obese, to get near the actual nerve. So, and what are the solutions? Ask if the patient can get some pain relief so that you can press a little harder, or just wait until the edema goes down. Okay, poor but detectable response. So you know you're getting a response, it's just not very big. Well, again, it might be an obese patient, or you just maybe need to increase the stimulation, move the stimulating electrodes. Sometimes just the orientation has to be changed a little. But there may be a real, physiologic explanation. It's not happened to me very often, but I've had a patient where I know there's temporal bone fracture on one side, and that's the side everybody's worried about. The patient's unconscious, they're in the neurointensive care unit, but I can't get an ENoG from either side. Doesn't make any sense. I was expecting to get a beautiful ENoG from the side without the temporal bone fracture. And so I started looking through the chart. Finally, I went out and tried to track down some family members, and I just very tactfully asked them about their loved one's facial nerve function. It turns out they'd had Bell's palsy on the side where out that didn't have the trauma, and so I had no way of comparing the involved. There, both sides were involved in this case. So that's only one case out of hundreds and hundreds, but it could happen. Now, with the obese patient, particularly if the patient is in the intensive care unit or the operating room, you can always use needle electrodes. I've used them many times, and you can actually poke through the skin and then get a little closer to the nerve, and that usually will solve the problem. Okay, poor response. Unilaterally, and almost always means you're not stimulating where the nerve is coming out of the head. Of course, you can't see it, so you just have to move around and experiment until you get a good response. And then too much artifact, well, sometimes it's because the response itself is so large, so you have to just reduce the amplification. Sometimes it's because you've got the electrodes that you're recording on the face. Some people want to get the electrodes out of the way. They put them behind the ear, kind of keep them off the face, or, the wires. Now, the electrodes are on the nasolabial fold, but the wires go over the ear. But of course, that's right where you're stimulating. So you've got to make sure you keep your stimulating electrodes as far away from the recording wire electrodes as possible. And sometimes you just need to eliminate the artifact reject so that you can actually see a response. Okay, and then the final troubleshooting uh, issue we've already talked about. If you see a big response, but it's occurring too early, the response should be somewhere in the 10 to 15 millisecond, 10 to 20 millisecond region. That's the real facial nerve. It takes that long to go from the stylomastoid fragment for the neural impulse to go down to the mouth area. But if you're seeing a response at 6 milliseconds, I mean, that's just too small. Not, and if it's a child, a small child, maybe, but not for an adult. So that's always masseter muscle, and it's not what you're recording. All right, well, that's ENoG. Took a little longer than I thought, but this is the one topic of this 3 the three that we're covering kind of on this quiz 4, ENoG, somatosensory, and intraoperative monitoring. This is the topic that you need to know more about than the other two, because some of you may very well end up doing this clinically. All right, well, that's the end of this PowerPoint, and we'll talk about it in the next class that we have, so you'll have a chance to ask questions.